I want to welcome commissioners and members of the public. My name is Commissioner Wang, and I will be the acting chair. Today, as Chair Sargent is unable to attend this meeting, I'm a stunt double. You can't tell us apart. This meeting is a hybrid commission meeting. There are several commissioners in room 100, the best ones, and the rest of the commissioners are participating by Zoom. You should be here today, really. Given that this is a hybrid meeting, additional ground rules will still apply. I will begin this meeting with a roll call of commissioners. During the meeting, I'll ask the commissioners and presenters identify themselves before speaking. That way, commissioners and members of the public will know who is talking and have the same knowledge of who is in room 100. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by me. Due to the possibility of background noise, I ask the commissioners and presenters, please mute their electronic devices when they're not speaking. I'd also like to ask commissioners attending remotely to avoid putting substantive comments in the chat because the screens are very far away and I can't see what's on them. MHCC posts documents that will be acted on or discussed at least a day in advance, so the members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. I will now call the roll. Commissioner Bandari.
Here.
Thank you, sir. Commissioner Blake. Commissioner Blake.
Here.
Thank you. Commissioner Boyle. Commissioner Brzezinski.
Here.
I see you in the room. Thank you very much. Commissioner Cheatham.
Here.
Thank you. Commissioner Douglas. Commissioner Douglas. Commissioner Gelrud.
Here.
Nice to see you. Commissioner Gilmore. Commissioner Gilmore. I see you.
She's here.
How you doing?
Maybe, you're not.
Now you're muted. You're unmuted. Hi. Well, Commissioner Gilmore's here. Commissioner Jensen, good to see you, sir. Thank you. Commissioner Agbabiaka, formerly known as Commissioner Ojikutu, congratulations.
Here, thank you.
Commissioner Spinner.
Here.
Commissioner Stroden Duncan. Commissioner Wood, I see you.
Here.
Fantastic. All right. Move on to agenda item number 1, interaction of consent agenda. So it's the approval of the minutes from the July 18th, 2024 Commission public meeting and our request for a post-approval project change for the certificate of need, the Chesapeake Eye Surgery Center, to establish an ambulatory surgical facility in Anne Arundel County. Any comments on the motion for the approval of the minutes from the July 18th, 2024 meeting? Anybody? Sorry.
Approved.
Thank you very much. In a second.
Second.
Thank you so much. Any discussion? Do we approve? The ayes have it. I'm calling question. Anybody? Hearing no objection, we're going to approve the minutes. And I'd like to move to the consent agenda. MHCC's procedural regulations allow for this type of project change on the consent agenda, as it is a capital cost overture that exceeds the allowable amount, and there is no change in the financing mechanism. This is a late addition to the consent agenda as a project change request was submitted untimely. However, the project overage on cost was noted in the quarterly reports, which is not flagged by staff. Does any commissioner wish to remove an item from the consent agenda? Hearing none, is there any objection to adopting the items of the consent agenda? Hearing no objection, consent agenda is adopted. Agenda item number 2, the update of activities. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Dr. Stefan, would you kind of provide us with your updates?
So, thank you, Chair Wang. So I could make a statement today and say, we are on a bit of a shortened time period. We'd like the meeting to end at 3:30. So I'm going to cut short my presentation. But the real truth is I left the notes in the other room. So I'm going to just focus on a couple points that I think the commissioners need to know right now, today. But I will follow up with a summary of what I was going to do is summarize the status of the various legislative reports that are due by later this fall or by the end of the year. I want everyone to be aware of what the status was. Just going to talk about a couple meetings that we've already had. In late August, we had a meeting. We called it the Trilateral Primary Care Meeting. It included all three work groups that are involved in the promotion, diffusion of advanced primary care, the MDPCP Advisory Council, the Primary Care Investment Work Group, and a special primary care group that was formed to advise the state on the evolution of primary care delivery through the AHEAD model. The purpose of that was to make sure that all three work group members were essentially on the same page in terms of understanding the state's preliminary plans on moving forward with the AHEAD model. The secretary, Dr. Laura Herrera Scott, presented on the AHEAD model. And there were numerous questions about that. In general, the work group, I think I could characterize as feeling very positive and inclined to encourage the state to move forward. We then also heard a presentation by Dr. Gingy Lindsay, the new Chief Medical Officer in the Medicaid program, on the plans for integrating Medicaid into the advanced primary care model, the MDPCP program, which is a requirement under the AHEAD model. Dr. Lindsay kind of overviewed the thinking right now. It's not as easy as it seems, because in Maryland, as most of you know, Medicaid is delivered through 8 managed care organizations. They would contend that some of the services and their approaches are actually include elements of advanced primary care already. There's also, of course, the issue of if this is going to cost money, who's going to pay for it? So not insignificant concerns if the program is to take root along the same dimensions as the existing MDPCP program is, with the additional payments to physician practices for care transformation, for example, and elevated payments for non-visit-based services that are integral to the MDPCP program. Nothing has been decided there, but then I think it was a good first step to orientating everyone in terms of what Medicaid needs to do. Finally, Ken Yates Trotman from our group, from our organization, presented data on, surprise, surprise, there are some differences on the definition of primary care between the various approaches that have been put forward by the state and the federal government. Briefly, the primary care definition that our primary care investment work group has developed, which we also call the multi-state definition, includes what I would consider a more traditional definition of primary care. It includes, of course, family practice, general practice, general internal medicine, as well as within that domain, both obstetric services and behavioral health services that are billed under the aegis of a primary care practice. That differs from the definition that the federal government has put forward through the AHEAD model, which includes kind of all of the above, as well as standalone behavioral health and OBGYN practices. That's certainly is not a definition that we necessarily oppose, but the end result, as Ken showed, was that the latter definition, the federal government definition, means that the percentage of primary care spending as a percentage of total cost of care is about 2% points higher. And as we're trying to elevate primary care, it would be my perspective that a more traditional definition might be more appropriate to raise awareness that we really want to focus on what I would consider traditional primary care service. Certainly, many primary care physicians deliver obstetric services, for example, family medicine, particularly in rural areas, and Dr. Basinski can talk about that. Do that, but to specifically say obstetric practices would be primary care. I understand why oftentimes during a pregnancy, all services are delivered through that obstetric practice. But I think the tradition evolving in urban areas has been more specialization of obstetrics. And certainly in terms of behavioral health, as important in many cases as primary care. But I think if I talk to historically people I have seen in behavioral health, they would have no idea if I told them they were now also defined as primary care. And I think it will significantly elevate the percentage of primary care services if we included both of those specialties. But we're going to have to kind of bend with the preferences of our CMS colleagues as well. So no decisions were made on that, but we made sure that everyone kind of had the sense of what needed to be done, particularly as it relates to Medicaid reform or Medicaid transformation, if you will, as well as the options moving forward in terms of the definitions. The second update I just wanted to provide is about that same time, late in August. Winnie Hawk, Tracy DeShields, and I appeared before the Health Government Operations Work Group that was convened as a result of a bill that did not pass HB 805, which would have removed behavioral health services from the scope of CON, specifically inpatient behavioral health services. As all of you know, there have been significant challenges with providing acute inpatient behavioral health services that kind of goes back a couple of decades, but it was certainly more challenging in the last few years, particularly exacerbated by the pandemic. And a junior member of the legislature concluded, without a whole lot of evidence, that the real problem was CON. We explained the CON program to the legislators. And to be frank, there were some legislators who believed, let's get rid of this, or let's get rid of this for a while and see what happens. We pointed out that this is a little harder to do than you might think, because when we regulate bed capacity in hospitals, we regulate overall bed capacity by providing hospitals with a window to add behavioral health capacity. They could then, after a year or two, convert that to acute general or obstetric or pediatric beds without any intervention on the part of the state. There are probably some things that could be done, but we felt as though preserving the authority of the Healthcare Commission to award new behavioral health beds was probably the best idea, with then looking at ways in which we could make this flexible. I might add that we have no backlog on any applicants wanting to add behavioral health beds. We have, over the last 5 or 6 years, whenever anyone has come forward, we've approved that application without a lot of duress, with the exception of some of you remember 3 years ago, Commissioner Boyle served as a reviewer on an application to create a 20-bed pediatric and adolescent behavioral health hospital in the Security Boulevard area of Baltimore. That was being built in an office building. There were considerable issues with funding, particularly that application. It was rejected by the commission. But we did encourage the applicant to perhaps seek a partner, established hospital, if you will. Nothing materialized with that application. And as we said to the legislators, we're not aware of anyone having any undue challenges in obtaining CONs for behavioral health services. Certainly, in February of this year rather, Hartford Memorial closed and opened its ambulatory campus in Aberdeen, Maryland. That campus includes a 32-bed behavioral health standalone hospital. So up there, they took the behavioral health service, inpatient services, which were part of Hartford, and carved that out into now it's a specialty behavioral health hospital. And I think it's well configured to serve residents of that area. But certainly we recognized and affirmed to the committee that we too were concerned and working on a host of different measures, including the work that Tracy DeShields is doing with our consultant on the behavioral health workforce, with the work that David Sharp is doing in terms of payment adequacy for professional services, behavioral health professional services, and just generally the support that we are going to be providing in terms of analyses on use of behavioral health services. The most upcoming one is one that Shankar Mehta is doing on comparisons of access to behavioral health services between traditional Medicare and Medicare Advantage, which now is a more dominant product in the state of Maryland. Historically, Medicare Advantage has not been significant, but over the last 3 to 4 years, it's seen steady growth. Now, 25% of the Medicare beneficiaries are covered through Medicare Advantage plans in the state. Not Pennsylvania, where 50% of the population or more is in Medicare Advantage, but certainly growing and an important part of care delivery here. So we are going to be reappearing before this work group in early October to talk about some options. We will share our ideas for options with the commission, or we present them to the work group if we have anything that's significant. The other point I wanted to raise is I wanted to update you also on the status of the numerous projects that we do have to complete by the end of the year. And I'll send that through an email to all of you, but happy to take any questions.
Commissioner Galbraith,
Yeah.
thank you. I just have one comment in looking at the definition of primary care. And I want to underscore a little bit and even expand what you said about OBGYN in rural areas, because it is my belief that it's not just during pregnancy, but a lot of women, when they go for their annual GYN visit, those docs in where you can't get into primary care easily are doing a full scope of, or a fuller scope, I'll say, of primary care for those ladies.
Yeah, and that's one of the arguments I think we heard of why should be counted. I think we'll keep you all informed. Dr. Brzezinski is on one of the work groups and also probably has some commentary he wants to offer.
Certainly. With the scope of OBGYNs, it's interesting. It's been a debate. I can remember back to when I was in medical school in the 90s. Is OBGYN primary care or is it specialty care? And there's elements of it that are clearly specialty care, surgical procedures, so forth. Our healthcare system reimburses procedural medicine at a much higher rate than primary care medicine. There are elements of OBGYN care that is clearly primary care in terms of screenings for cancers and other health conditions, mental health screenings and so forth. And some OBGYNs really embrace a lot of that primary care. Others are very much surgical specialists. And so they've always been on both sides of the fence there. And it's a hard decision to know where to place it. And, if there's a way to do it by procedure, as a hysterectomy, primary care, probably not. As a pap smear primary care, definitely. So that it's led to a lot of conflict. And if really the goal, what's the goal of these new systems, healthcare redesign, funding strategies is to elevate primary care in Maryland, because historically primary care has been underfunded, under-resourced. And I think that contributes to a lot of the, health inequities that we see when people can't find a primary care doctor. They end up going to specialty care or emergency rooms. So, fund in a way that achieves the goal that we want. Paying more money for hysterectomies is not enhancing primary care. Paying more money for pap smears, mammograms, and all that, and empowering physicians and resourcing physicians to do that is what we want. So, these spending targets were set to enhance the availability of primary care, because, in my opinion, that's the only really value proposition left in healthcare, is to have patients receive more and better and advanced primary care, as opposed to gravitating towards higher acuity settings, either because they don't get care and end up hospitalized, or they can't find primary care and they end up getting care in an emergency department. So I embrace anything that would help empower and resource true primary care for patients. And the OBGYN question, I think, will always be debated till we can do it by procedure or something like that. Consider not just the specialist, but which procedures of that specialist.
That's a great point. I mean, the fact that what is the ultimate goal of this entire debate? It's not academic. It's how do we deliver more and better primary care to our citizens? They
Right.
need it. It's coming through an OBGYN. My mother's an OBGYN for many years, and that's how it's got to be done. We'll have to see how we settle that definition. Commissioner Cheatham, I know you serve on one of the primary care work groups. Would you be interested in making any comments on this debate? It's okay. All righty.
This is
Thank you,
Commissioner
sir.
Bhandari. I will
Commissioner
make a
Bhandari,
comment.
yes.
Yes. So Dr. Brzezinski is absolutely right. I'm doubtful if any OBGYN write medication for diabetes, hypertension, or hyperlipidemia. So OBGYN, in my opinion, majority of them are specialty care. I will tell you another, wrench in the wheel. Now we have a lot of hydration clinic, weight loss clinic, aesthetic clinics run by many doctors or nurse practitioners. Are they going to be part of primary care? Because a lot of those are either paid cash or they can take insurance, and these are very easy jobs. What Dr. Brzezinski is doing is very difficult job. So his practice and primary care should be paid more.
Hi, sorry, I was having difficulty getting myself off of mute. Completely agree with Dr. Brzezinski. And what we're seeing now is they're within the OBGYN specialty, they are changing. They're going into different tracks. So you have, the surgical side of that, or they're just doing labor and delivery. So they're further delineating what they do. So I think as we continue to watch that specialty evolve, I think they're gonna more and more setting themselves apart from being truly primary care.
All right. Thank you very much. We'll move on to agenda item number 3, action proposed permanent regulations, Comar 10.25.10, Maryland Trauma Physician Fund regulations. These regulations govern the Trauma Physician Services Fund. The primary purpose of the proposed regulations is to conform to the statutory changes made in Senate Bill 1092, House Bill 1439. The new Trauma Physician Services Fund regulations increase the amount of money distributed to the fund by adding a new funding source and raising the motor vehicles registration fee from $5 biannually to $13 biannually. The fund also expands reimbursement opportunities for trauma centers by defining who is eligible for reimbursement in certain situations. Finally, the proposed changes increase the number of hours and the percentage for on-call reimbursement. Tracy DeShields, our wonderful Director of Policy Development and External Affairs, will present the proposed permanent regulations to the commissioners, hopefully with another very funny ending slide. Tracy, please proceed.
Sure. Good afternoon, everybody. Good to see you. And I'm going to do a high-level overview of the proposed permanent regulations with regard to the trauma center, 102510. Next slide, please. Oh, we're there. Okay, so just generally, there's four, well, different components of the trauma fund, specifically on-call, uncompensated care, grants, and MHCC administrative costs. Next slide, please. And just as a reminder of just a little bit of history with regard to the fund, it was established in 2003 by the General Assembly, and the purpose was to help reimburse trauma physicians who incurred costs related to uncompensated care losses, and by raising Medicaid payments to 100% of the Medicare rate when there was a Medicaid patient who received trauma care. It also established formula for reimbursing trauma centers for trauma-related on-call expenses for surgeons, orthopedists, neurosurgeons, and anesthesiologists. These are the 4 specialties that are required to be on call or on site for trauma care under MIMS regulations. It also allowed the HSCRC to allow hospitals to include trauma related standby expenses into their rates, their report on to get approved rates included in that. Also, as mentioned by Commissioner Wang, he said that the fund as of June 30th, 2024, we collected $5. It's biannual fee from the Maryland registration, motor vehicle registration fees, which goes into the fund, and we get that. That has been that was increased to $6.50, and so biannually that would be $13 increase for that, and that became effective July 1st, 2024. Next slide, please. Over time, there have been some updates and amendments to the fund and what it could be used for, in particular around uncompensated care and Medicaid reimbursement. The addition to level 2 and level 3 trauma centers being able to receive on-call payments, as well as the Children's National Medical Center being allowed to have a grant from the fund. Also, uncompensated care payments were provided to trauma centers, affiliated rehab hospitals, and lastly, the shock trauma became eligible for standby payments from the fund. Next slide, please. So as of this legislative session, 2 bills were passed: Senate Bill 1092, House Bill 1439. And this also made changes to the fund. And these changes were based on recommendations that came from the Trauma Fund Commission that started 2023 through February 2024. And as of June 30th, legally, it doesn't exist, but we can always bring it back if need be. So the legislation, as I mentioned, did increase the amount that we received through motor vehicle registrations. It also allowed for monetary penalties through DUI. They increased that penalty from $1,400 and to $2,400. 20% of any of those monetary fees would then also go into the trauma fund. We have no experience with the trauma fund, so we don't know exactly what that's going to be. And obviously those are court imposed, so they're probably more than likely waived in some manner. And so we don't know. So we'll see how that flushes out for this year. We do know in past years, we've basically received about $12.3 million per year for the trauma fund. This year, we think with the increases, could be anywhere close to about 30 million, per year. We don't know because certainly registrations probably ebb and flow, through the year, but we'll see, so far how that works out. Next slide, please. So with that, we are required to, do regs or update our current regs related to, the trauma fund. So in it, we added the definition for trauma healthcare practitioner. And that sort of extends to, healthcare practitioners that work, in the trauma center, and that those are also required under, the MIMS, regulations. Also, the definition of service period, was changed to include a subsequent admission or outpatient visit, to a trauma center or affiliated hospital, units. It also expands, before we were allowed to give grants, but the grant was only limited to equipment. And so now, that restriction has been removed. So we could look at expanding, what grants, trauma centers are able to apply for. Could be for, maybe, patient education, could use it for equipment, services, systems, trainings, other MIMS required incremental trauma costs not otherwise covered, through rates. Also, the Children's National, Medical Center now can receive, $590,000, as a grant from the trauma fund. That has been increased. It can go up to $900,000. It also now includes, Hopkins Children's Center. They do some trauma there. So, in the legislation, I think it says that we can give a grant for, pediatric trauma centers, up to 1.8 million. So if you flush it out, it would be 900,000 apiece. It also increases the maximum number of on-call hours that, trauma centers are able to apply for. And then, it allows, MHCC along with HSCRC, to look at the reasonable compensation equipment hourly rate. And, we can now, go up to 60% of the rate of the Medicare Economic Index. So that's part of the formula that we use to determine on-call reimbursement. Next slide, please. It also now allows, or explicitly allows, for audits on, with regard to, on-call, reimbursement claims and uncompensated claims. So we can do that. We removed the reporting requirement. It is very detailed in the statute. It also, says what the commission's, expenses that can be covered by the fund, so any administrative costs. And then it limits the time frame in which an uncompensated care claim can be filed to 5 years, after the date of service beginning July 1st, 2024. So those are some of the major, changes. We did have, next slide, please. We did have, 3 stakeholders reach out and provide, had some questions for clarification, in which we, responded, to them. And we have a couple of additional things that we need to respond to that were asked of us from the same stakeholders. So, and that's would conclude my presentation. And unfortunately today, I don't have a funny slide.
Disappointing.
No,
Thank you, Tracy.
you're welcome.
Do I have a motion to approve the proposed permanent regulations, Comar 10.25.10, Maryland trauma? Commissioner Bazinski has made the motion. Is there a second? Second. All right, Commissioner Stroton Duncan, thank you, sir. Motion is second by Commissioner Stroton Duncan. All right, folks, any discussion? Tracy, why are we only getting 20% of the DUI? Why not all of it?
I don't know. Some of it is also going to, towards, I believe, shock trauma.
Oh, yeah. It's all gonna be good calls.
That's right.
I think it's great you include the audit in there as well. The
Yes.
audit to make sure that the money is being spent, the money is being spent properly. That's great.
Mr. Wang, maybe they should increase DUI fee because a lot of trauma care is done for the DUI patients.
Absolutely, Commissioner Badar. There's definitely a relation, right? DUI and trauma.
Yes.
All right. No further discussion. All in favor?
Aye.
Aye.
Anybody against? The ayes have it.
Thank you.
Hereby approved. Thank you very much. All right, moving on to agenda item number 4, action proposed permanent regulations. Omar 10.2.4.1, procedural regulations for healthcare facilities and services. Hello. The next agenda item is a presentation of changes to 2 sets proposed permanent regulations. The procedural regulations for healthcare facilities and services and the state health plan for comprehensive care facility services. And these proposed changes are implement the provisions of the 2024 legislation related to the acquisition of nursing homes. I wish Commissioner Boyle were here. Presenting will be Director Whitney Hawk, the Director of the Center of Healthcare Facilities and Planning, and Jean Marie Gowell, the Chief of Long-Term Care Policy and Planning. Winnie and Jean Marie, please proceed. Yes.
Before they begin, I just want to commend all the staff that have worked on this. Includes the staff of planning, includes our attorneys, Tracy Shields contributed. And also note that we were aware of Commissioner Boyle's concerns and interest in this area. So Winnie, Jean Marie, and others had a briefing with her before she left on her trip. So she, in general, heard this. And if there's anything you want to share on her perspectives during the presentation, feel free to do so.
Absolutely, sure. Hey, good afternoon, Chairman Wang and Commissioners. I'm really pleased to be here at this time to walk you through the changes. Give you a little bit of background, the timeline, and on both the procedural regs and the nursing home regs. Oh, I didn't even have to say next slide. Thank you, Madeline. So just real quickly, I'm going to walk through this quickly, like how did we get here and what was behind all of these changes. You know, you had things that were happening on the federal level. You can see where Maryland was ranked in terms of the numbers of acquisitions. Before the second bullet, actually, there should have been another bullet because in 2020, there was an article in the Washington Post, and it was about the Porta Piccolo group. And it was, and at that time, they were, during COVID, acquiring a huge number of nursing homes. And it was during COVID, and they started to look at what that group was doing and what was happening with nursing homes post acquisitions. And there was some concerns that there was correlation between declines in staffing and quality. And that's what the federal data was showing. So and then what happened with the commission, this was before my time because I came in 2021. Paul Parker, the director at the time, then started to independently look at quality and assess quality in our acquisitions. And on those monthly reports that you get, you can see that there has been an assessment of the CMS 5-star ratings and the quality. And there was always that little tagline that said, if this were a CON, it would not qualify to move forward. And what it did is it highlighted essentially the limits to the authority of the Maryland Healthcare Commission in these types of transactions. So then we began working with OHCQ and trying to look at the changes of ownership and track those a little more. Federal government started to get more involved through MedPAC, the CMS, and the White House. And so at the end of the day, I think there is a highlighted interest in public, in private equity ownership and acquisitions and what happens post acquisition. So next slide, please. So there was the 2020 Porta Piccolo article. 2021, we incorporated the quality reviews. In 2023, then the General Assembly passed legislation and required a work group, the Maryland Healthcare Commission, to study and assess nursing home acquisitions and specifically look at the multiple bed patient rooms with more than 2 beds. I suspect that was related to the high infection rate of COVID, of infections during the COVID pandemic. And then sort of the broad address any other issues related to acquisitions, and the study really focused on the impact to quality that related to private equity ownership. So then that led to a report that was filed in January 2024, resulted in legislation that then generated a new process for assessing acquisitions. So what the legislation that passed earlier this year required is the commission to update the regulations that relate to acquisitions. It was at a pretty accelerated timeline because the regulations that relate to acquisitions, there is a sort of hopefully January is the deadline for the adoption of the regulations, which is pretty accelerated. So we changed the process a little bit, and staff, including our wonderful attorneys who were very helpful in this, and Jean Marie, we worked very hard. We didn't include a huge work group. We drafted the revisions to the state health plans because there's an acquisition component to the procedural regs, but there's also, we're still on the timeline. So thanks. And so what we did, we drafted the proposed regs, and we then posted on the website, solicited comments from any stakeholder that was identified either through the legislative process or the past revisions, which the most recent update of the chapter was in 2019. So we went back and engaged all of those stakeholders. So we circulated the draft. We received 6 comments, we posted it, and then we held a webinar to go over the comments. We gave all of the participants another week after the webinar to submit any additional comments post that meeting, and therefore we were on a deadline to get it to this meeting. So that ended September 6th, and we did compromise the language with based on some of the comments. And we'll get to those. Next slide, please. What were the key changes to acquisition? So, one of the issues that was a compromise during the session was what percentage ownership acquisition should we be looking at? We were CMS goes as low as 5%. We were a little worried about the volume. So what we did there is we're reporting ownership transfers of 5%. And they're to give us notice at this time. It's not part of the approval of the approval process involves 25% ownership or greater. We're going to track the 5% to see what that looks like, and there may be adjustments in the future. The definition, so then you see the definition of an acquisition. So there's a 60-day notice requirement for those that require approval. There's a 60-day notice to us, but what's also been included in added bonus is that the residents and the facility employees also get notice of this potential transaction, and they can submit comments. The really big change is the next bullet, where the executive director has the authority to approve with conditions, deny or refer the nursing home acquisition to the commission. So you're not going to get every acquisition. So we're trying to limit what came before this commission, but to the extent it's deferred or appealed, then this body would consider the acquisition. Then another big change is, in order to be able to make better policy decisions, there is a post-acquisition annual report for 3 years post-acquisition, and so so we'll be able to see what happens. And you'll see the parameters of that report. Next slide, please. So the required regulatory provisions, I don't know that I need to go through this, much more detailed ownership information, both before and after. I think the management contracts and other disposable parties is new, and that's going to give us more, better ideas about who's involved in these facilities. There's a minor change, and I think Jean Marie will talk about the specifics on the participation in Medicaid. And then back to the acquisition, the nursing home acquisitions work group, there's the elimination of the triple and the quad rooms, 3-year reporting requirement. And this law will become effective October 1st. However, it will not apply to any nursing home, any acquisition until the regulations are adopted. Next slide, please. So the other thing that we found as it relates to the quality standard, and I know that Ben has talked about this a lot, is that are currently we're requiring to, in order, it's like, it's almost you cannot pass go unless you have 3 stars or better based on the CMS 5-star rating. So it's a bar to any applications if you can't meet that particular standard. So during COVID, it became a problem because the Office of Healthcare Quality did not conduct surveys, and they were really focused on inspections. So many nursing homes didn't get a survey. So you were sort of locked in on whatever your rating was. And that was, and there could have been potential worthy projects to move forward. So we found that the strict requirements of that 5-star standard were, was a barrier. And we thought that these proposed changes would help ameliorate that. And with this, I'm going to turn it over to Jean Marie, and she can go through the further details on the 5-star rating and the changes.
Next slide. Okay, so for this slide, just stay here for a moment. This is the 5-star formula. The 4th bullet is the one that I just wanted to bring a little bit of attention to. So if inspections, the inspection star are below a 1, the overall rating cannot be upgraded by more than 1 star based on the other 2 metrics. So as Winnie mentioned, the problem is our surveys are behind. There are many nursing homes that haven't been surveyed since 2019. And so you can see where this would cause issues in the ratings. Next slide. Okay, review of comments. Next slide. So we received 6 different sets of responses, and they were from the Marylanders for Patient Rights, HFAM, 1199 SEIU, Maryland Department of Aging, Lifespan, and Leading Age. We don't have a separate slide here for 10.24.01, but we did receive a few small comments about the procedural regs, just to mention. One of them in the acquisition language, the commission was to provide information. I mean, the applicant was to provide to the commission any conditions, and the change that they had requested, the stakeholders had requested, is that it would be just conditions that were still in effect. So this would not be quite as much information. So we made that change. We also changed the definition of a merged asset system. And we also did change the definition of a CCRC based on feedback from the Office on Aging. Next slide. Key areas of interest. Each one of these has its own slide, so I'm just gonna skip over this summary slide. Next slide. Okay, acquisitions of real property only. So this was really the issue that we received the most feedback from and the most concern about from our stakeholders. The concern is that the commission does not have jurisdiction over real property, real estate only transactions. Currently, when we receive our notice, we have information that comes in on who owns the bed rights, who owns the operations, and who owns the real estate. So what we have done and what we're suggesting is really a compromise with an exemption. So if it is only a real property transaction, we're suggesting that there be an affidavit that the applicant can sign saying that there will be no role in facility operations from the real property owners. And so that way we're kind of meet in the middle. So that's what we proposed there. Next slide. Okay, Medicaid participation. So the spirit of this has not changed, but what we're proposing here is to leave the Medicaid in and take the MOU or Memorandum of Understanding out of it. The reason why is that the Memorandum of Understanding is outdated. We don't have any data on it since 2017. Only half of the nursing homes in Maryland have an MOU, and it is not enforced by Medicaid. So now when applying for a certificate of need, you have to meet the MOU, or we ask that the applicant get an MOU. What we propose is that all nursing homes applying for a CON or other commission approval must meet this threshold for the county or HPR, health planning region, whether they have just getting rid of the MOU, and everyone who comes forward for the CON has to meet that threshold. The thresholds are published on the MHCC website and would continue to be. Next slide. Oh, I'm sorry, before I do that. The CCRC exemption here, there were comments from our stakeholders that they wanted to make it clear that CCRCs with exempt beds were not a part of this, that they were exempt from this, and so we made that clear in the changes. Okay, now next slide. Okay, quality, as Winnie mentioned, this is the part of the state health plan chapter that we had lots of feedback about from stakeholders about it being very black and white. And so what we've done is we've made two different layers. So the first layer is we're still going to have, if you're in Maryland, we look at Maryland facilities. If you are not in Maryland, now we're just gonna look at the state with the largest number of nursing homes in it. So whatever that state is for that particular applicant. So if you meet the 3 stars, that's great, and that's the first layer. But then if you don't meet it, you have the opportunity to really take a deeper dive, a more holistic approach, however you want to look at it, and give us more information on your quality performance. So what this includes are quality assessment and assurance committees, documentation of infection control and vaccinations. And here the stakeholders asked us to add COVID to the list of vaccinations, which we did do. The family satisfaction of care, which is a wonderful resource that we have that we collect here at the commission that has both qualitative and quantitative data. So we added that here as surveys and corrective action plans and any lawsuits, special focus facility designations or harm tags. So we would take a look at all of that and then we would be able to make an assessment on the quality rather than it be just black and white. Next slide, please. Okay, waiver beds. So currently, waiver bed rules say that you have to reduce to the maximum extent possible any triples or quad beds. The stakeholders wanted to add that they should be able to add waiver beds to renovations or replacement facility projects. Those are not projects that usually involve certificate of need. We did clarify that this is okay, but we are asking that all triples and quads be removed, not just to the extent possible, but they are all removed, and that the projects must be completed within a year. Next slide. Okay, so we're at the staff recommendation. So we're asking the commission to approve the draft regulations using 2 separate motions. The goal is for these to be published in the Maryland Register and another 30 days be allowed for another comment period. And then, as Winnie mentioned, we hope to be finished by January of 2025.
Great.
That concludes our presentation. Any questions?
Thank you very much. And by the way, thank you so much to you and your team for pulling all this together so quickly. All the comments, all the stakeholders, and turning it around in time for this meeting. I think it's incredible. And this is something that's very important, right? I love private equity, but it's undeniable that the incentives of private equity are not always aligned with the incentives of public health. And what's good for private equity is not always good for public health. This is so important. So do I have a motion to approve COMAR 10.24.01 procedural regulations for healthcare facilities and services?
Motion approved.
Commissioner Brzezinski's made the motion. Is there a second?
Commissioner Cheatham, second.
All right, well, Commissioner Cheatham, the motion is second by Commissioner Cheatham. Thank you. Discussion. Commissioner Gilbert.
So thank you. This is really great work. I just have to ask a couple of points around the quality work. So if you don't make 3 stars, then you get the opportunity to share different or more data. I love that family surveys are included. I think you glean a ton from that. But the fact that they have quality committees that meet quarterly is like such a low bar compared to, how do we know how many people are getting bed sores, and how do we know how many are developing sepsis and bounce backs to hospitals? And I'm a little worried about it. My background is quality, of course, and so I tend to gravitate to looking at that more deeply. But what happens if they're having their meetings and they can demonstrate that infection prevention, there's not a closed down for spread of diseases, but the care's not right.
No, I think that that's a really good point, and I think we have to balance between what we can review. So right now, we're really just looking at dates, like, are these meetings being held? Are they being held quarterly? I mean, we could look at expanding that, to your point, and putting some more meat there. So that is something that we can look at, and if you have specific recommendations on how we could do that, we would certainly be grateful to hear those.
Commissioner Brzezinski.
Isn't some of that data covered in the surveys, in the OHC surveys, OHCQ, whichever, the Office of Healthcare Quality?
And that's,
Is it like some of that level of granularity, isn't it already
Mhm.
tracked in there? And
There's a whole
you know,
star.
there's a reporting, like a reporting requirement for contagious disease and so forth. I seem to recall that from my medical director of a nursing home days.
Yeah, there is, and there's a whole star for just quality measures in the nursing home, which will give you some of that data about what you were asking about, but.
You know,
maybe-
having worked in a nursing home, there seems to be a lot of reporting requirements already, and I'd hate for us to be duplicative of what's already existing. So, I mean, if any of this, okay, I agree that quality needs to happen. It needs to be, there needs to be oversight, and some bad things have happened in nursing homes. But I don't want us to end up creating duplicative work for these facilities and so forth. And I would say if we, if we look into that, we don't want to
Right.
redo work that's already being done by OHCQ.
I
Commissioner
agree a
Alstar.
million%, sorry, but I just want to make sure there's something of that included here. Not redo it, but use it.
No, thanks. Commissioner Duck, please.
I wanted to mention, I really do think the getting comments from the residents or the representative is huge and a big impact. My question is, what about the vendors like yourself, going back to overseeing laboratory in nursing homes? What if there is some comments from a vendor? Would they go through the normal CMS line, or is there opportunity here to collect comments from them? So for just example, your laboratory services would not be a part of that thing, but they are seeing these patients. They are seeing that quality angle of it. They are handling infection levels. So I was just curious, is there, should they go through this route, or is it the normal CMS reporting route for any concerns?
Yeah, we could possibly expand it to also put contractors and vendors there, not just residents and staff. It's a good suggestion. Open to this, yes.
I have a question about the data collection with the family satisfaction of care data. Are there any standardized data collection tools currently in place to make sure that we're actually getting quality data about the patient experience? Because I would hate for a nursing home to just throw something together and it looks like the patients or the family are more satisfied than they are because they didn't have a good data collection tool to collect that information.
I think actually Stacy's here. Do you wanna come up and answer that question? To put her on the spot, she's She's the expert.
Would you come up and?
Essentially what I'm trying to get at, is there any standardization around collecting the patient and family data, just to make sure that we're getting quality information and nursing homes aren't just like throwing anything together or asking the bare minimum and looking like they are providing better care than what the patients or residents really, patients or family members really feel like?
Yes, we collect the family member satisfaction survey that I reported on a couple of months ago.
Oh, okay.
I remember that now.
Yes,
Yeah, I remember.
Remember what month it was just a few months ago. But yes, so we do that every single year. And we send it out to the family members of every single nursing home resident, the family members of every single nursing home resident in Maryland.
Really intense follow-up, right?
It's
With the phone
incredibly
and-
intense.
Yes. Okay.
Yes, so it's standardized, takes about
Okay.
10 months from beginning to end. So yes, it's standardized.
Okay.
We do it every year.
Perfect, thank you.
Yes, you're welcome. Then-
Sorry.
All right. All in favor?
Aye.
Any opposed? And then also action Comar 10, we're doing this separately, right? 10.24.01 procedural regulations for healthcare facility services is hereby approved. Do I have a motion to approve 10.24.20, the state health plan for facilities and services, comprehensive care facility services? Commissioner Duncan has made the motion. Is there a second?
Commissioner Cheatham, second.
Well, so we got B, the punch from Commissioner Jensen, the motion second, Commissioner Jensen, thank you very much. Have we had our discussion? Any discussion? All in favor?
Aye.
Aye. Aye.
Any opposed? Action 10.24.20, the state health plan for facilities and services, comprehensive care facility services hereby approved. Going once, going twice. Thank you very much.
Before you leave, so these are proposed regs. There will be a 30-day comment period after publication. We would expect these regs to come back for possibly final action in December.
I hope December, it just depends on if we get any comments and if we have to make any substantive changes. So December is the target.
We have to make changes. Do we have to repost them for another 30
If
days?
they're substantive, it depends on the types of changes. So, look, I mean, I hope that we, resolve a lot of them by having a formal process before bringing it.
Wayne, Jean Marie, thank you so much.
Thank you.
Agenda item number 5, action certificate of ongoing performance application for PCI services. University of Maryland, Baltimore, Washington Medical Center, docket number 2402 CP049. The next agenda item for consideration is certificate of ongoing performance application of University of Maryland, Baltimore, Washington Medical Center, continue providing both primary and elective PCI services. Elliot Burke, Program Manager of the Acute Care Policy and Planning Team, will present the staff report. Elliot, the floor is yours.
Good afternoon, Commissioners. As mentioned, we're here to discuss the application of the Baltimore Washington Medical Center for continuation of provision of PCI services. Historically, Baltimore Washington Medical Center received approval to perform primary PCI in May of 2006 and subsequently received approval to perform non-primary or elective PCI in June of 2009 and continued providing those services under the waiver until 2020. In 2020, the hospital applied for and received a certificate of ongoing performance in July of 2020 and has been providing PCI, both primary and elective, under that certificate of ongoing performance since then. Baltimore Washington Medical Center filed its certificate of ongoing performance application, or renewal application as it is, in January of this year. Staff reviewed the application and the large quantity of documents that come with it and requested additional information from the hospital, and we received that additional information in July and August of this year. The slide in front of us now indicates the categories of requirements that PCI programs must comply with in order to receive or continue their certificate of ongoing performance. We can go to the next slide. First standard relates to the hospital having PCI services available 24 hours a day, 7 days a week. In the review period, 2019 through 2023, Baltimore Washington Medical Center's cardiac cath lab was available with exceptions for very brief periods of time when either planned maintenance or, in 2 instances, unplanned emergency maintenance was necessary. We ask routinely, and did in this case as well, whether patients needed to access PCI services during those times when the cardiac cath lab was unavailable. The hospital replied that it did not, so patient care was not affected by any of the very brief periods of downtime. There's another standard that hospitals achieve a door-to-balloon time of 90 minutes or less in 75% of their PCI cases. Baltimore Washington Medical Center met that standard in each and every quarter between the period of January 2019 and December of 2022. In fact, they achieved 90 minutes or fewer in 90% of their cases in 12 of the 16 quarters and never had an achievement metric less than 81.8% in any of those quarters. We further require that hospitals maintain a risk-adjusted mortality rate consistent with a high quality of patient care. Traditionally, consistently, we've interpreted that to mean that the hospital's adjusted mortality rate not be statistically significantly different than the national benchmark that's established by the National Cath PCI Data Registry. And if we go to the next slide, we'll see that Baltimore Washington Medical Center in each and every quarter during the review period was not statistically significantly different than that national benchmark. The first slide is showing us the STEMI or primary types of PCI, and the next slide, please, shows us their non-STEMI or elective PCI cases. And once again, the hospital met the standard and consistently was similar to the national benchmark. We can go to the next slide. Our regulations require that hospitals demonstrate that they are taking appropriate actions in response to concerns that are identified through their own internal quality assurance activities. In its application, Baltimore Washington Medical Center provided 8 different examples of issues that the hospital noted in its own internal quality assurance process, and then the steps it took to resolve those. In some instances, the hospital provided either very detailed descriptions or data indicating that the steps that they had taken for quality enhancement were effective. In other instances, MHCC staff were able to review the CAF PCI data registry reports and see independently our own objective evidence that the hospital's quality measures and performance improvement were effective. We can go to the next slide. Volume again is critical because the research has shown that when hospitals perform greater numbers of PCI, they typically provide those services with greater quality. So our regulations require that hospitals provide a total PCI volume of 200 cases or greater annually. Baltimore Washington Medical Center in the review period ranged between 304 and 337 cases annually. We further require that hospitals perform at least 49 cases of primary PCI per year. And again, Baltimore Washington Medical Center was well above the standard, achieving or performing, I should say, between 106 and 114 primary PCI cases annually during the review period. Our regulations require that there's a semi-annual external review of at least 5% of randomly selected elective PCI cases that the hospital has performed. Baltimore Washington Medical Center, like many hospitals in Maryland, utilizes MACPAC as their external review body. They again participated consistently, thoroughly in the MACPAC review process, never having fewer than almost 6% of their cases reviewed, which is above the 5% standard, and sometimes went all the way up to 23.2% of their cases being reviewed. In addition, there's a separate standard that for each physician, at least 3 PCI cases or 10% of that physician's cases be reviewed, which Baltimore Washington Medical Center achieved, as again, many hospitals do, through a combination of external reviews by entities like MACPAC and the hospital's own internal case review process. We can go to the next slide. Another standard we have for PCI programs is that the hospital develop a formal process for interventional case review, which includes meetings held at least every other month. Baltimore Washington Medical Center provided documentation indicating or demonstrating that the hospital was holding the regular case review meetings. We were also able to see that their meetings included not only physicians, but as is required by the regulation, technicians and nurses who care for PCI patients. In each of the years during our review period, the hospital had over 20 such case review meetings, which well exceeds the standard of every other month. We also require that hospitals convene a multiple care area group meeting. So that means involving all different parts of the hospital and the delivery care system that provide these services, including sometimes paramedics or the emergency department staff, in addition to just the cardiologists and interventionalists who actually perform the PCI. These meetings are supposed to happen every month according to our regulation. We have traditionally interpreted that to mean, I made this point during my last presentation as well, that the hospital meets at least 10 times a year or 11, as most hospitals that have monthly meetings frequently during either August or December or both will not hold their regular monthly meetings. Baltimore Washington Medical Center held this monthly meeting, and the meeting convened 10 times during 2019, 9 times during 2020, 10 times in 2021, and 11 times in 2022. When we noted that the hospital only had this meeting meet 8 times in 2023, we reached back out to the hospital and said, can you tell us how many times you have met in the first 8 months of 2024? And the hospital said, we've already met 7 times in the first 8 months of 2024. Staff decided to recommend that the commission still find that the hospital is achieving this standard. We require that primary and elective PCI only is provided to suitable patients, as there are other treatment options that are frequently available to these patients. So primarily for the elective cases, the method for determining whether PCI was provided to appropriate patients is the MACPAC reports. They assess whether the patient was appropriate for PCI or not by 3 different sets of appropriate use criteria. We look typically at how many cases during the review period were deemed rarely appropriate by 2 or more of the 3 appropriateness criteria. In this hospital's case, no elective PCI cases were found by MACPAC to be rarely appropriate by 2 or more of the 3 appropriateness criteria. We also look at how many patients received thrombolytic therapy when PCI services were unavailable. It should be noted that we're specifically looking at patients who received it because PCI was unavailable. There are times when a physician might legitimately decide that this patient is a better candidate for thrombolytic therapy than PCI. So we're specifically looking at how many times was PCI unavailable and therefore you had no choice but to deliver the thrombolytic therapy. That did not happen during the review period for this facility. I think during the July meeting, there was some discussion about also reviewing appropriate use criteria for primary PCI, which is not our regulatory requirement, but it did come up in discussion. So I will note that for Baltimore Washington Medical Center, we reviewed the CAF PCI registry data reports. 0 PCI patients with acute coronary syndrome who received PCI were considered by the CAF PCI registry to have received it in a situation that was rarely appropriate for it. 0. So they certainly achieved this metric of only providing primary and elective PCI to suitable patients. We can go to the next slide. So based on the above, the report that we submitted, staff recommends that the commission does issue a certificate of ongoing performance to permit the University of Maryland, Baltimore Washington Medical Center to continue providing primary and elective percutaneous coronary intervention services for 4 years. Before I stop and ask for questions, we just want to thank Baltimore Washington Medical Center for submitting their application and for making some staff available who are available virtually if there are any questions for the hospital. Cheryl Cole, who is Baltimore Washington Medical Center's nurse manager of their cardiac cath lab, as well as Selena Yedla, their data coordinator, plus Dr. Ratnakar Mukherjee, the medical director of the cardiac cath lab, and Dr. Beverly Young, who's their director of perioperative services, are available virtually if the commission has any questions.
Thank you, Elliot. Commissioners, do I have a motion to approve the certificate of ongoing performance applications for PCI services at the University of Maryland, Baltimore Washington Medical Center?
Commissioner Bandari.
Commissioner Bandar has made the motion. Is there a second? Motion is seconded by Dr. Buzinski. Discussion.
Just a curiosity why there were fewer meetings after the pandemic than during. Most places curtailed a lot of meetings during the pandemic, but they went down to 8 for that year, sort of at the end or post. Do we know why that happened?
I'm reviewing 4 of these currently, so I don't. To the best of my memory, this hospital, when we asked about 2023, said that there was a physician, a critical team member, I think it was a physician, who was ill on the day that these meetings were scheduled. And because these physicians have very intense meeting schedules, it's not that simple to reschedule a meeting that had to be canceled. To the best of my recollection.
Good catch, though. Great. All right, all in favor?
Aye.
Any opposed?
Aye.
Okay, great. The action for certificate of ongoing performance applications for PCI services, University of Maryland, Baltimore, Washington Medical Center is hereby approved. Thank you very much, Elliot. On to agenda item number 6, a presentation on the annual update on the Maryland Patient Safety Center. Included in your packet this month is the annual report from the Maryland Patient Safety Center, MPSC. As a reminder, Maryland state law authorizes this commission to designate an organization to serve as a patient safety center for our state to develop, coordinate, and implement patient safety initiatives. The current designation ends December 31st, 2025. As part of the designation process, the MPSC is required to update the commission every 6 months on their activities and accomplishments to ensure compliance with our designation agreement. Stephanie Pedito, did I pronounce that right?
Yes, you are.
President and CEO of the Maryland Patient Safety Center will now review the programs and accomplishments of the center. Stephanie, Teresa, please proceed.
Thank you very much. Teresa, is there anything that you wanted to say before I get started?
Yeah, I just want to mention that Commissioner Boyle is a board member of the Maryland Patient Safety Center, and she and Stephanie and I met before this presentation and went over everything. What it is.
Wonderful. Thank you very much.
Thank you very much. Thank you for having me here today. And before I start, I wanted to share with you that earlier this week was World Patient Safety Day. And World Patient Safety Day focused this year on diagnostic excellence and reducing diagnostic errors. And so, get it right, make it safe was their kind of call to action this year. And one of the things that we know about diagnostic errors is that they affect vulnerable populations more than they affect others. So there are significant racial and ethnic disparities in diagnostic excellence. And as we're going to be talking about more and more today, in addition to the to those aspects, an aging population, older people are more likely to experience diagnostic errors and have more significant impacts from those diagnostic errors. So that'll be kind of a little bit of a recurring theme today, is how we are also taking a look at vulnerable populations around patient safety. And so next slide, please. All right, so the Maryland Patient Safety Center, about 6 months ago, I came here for the first time. I've been in the job about 10 months, and our board asked us to evolve our strategic plan. And they want to make sure that the Maryland residents, Maryland patients and their families are at the center of everything that we do. And as I've gone through this strategic planning process that I will report back to you on next time, one of the things I just wanted to remind, as the chairman has said, is that the Healthcare Commission designates the state's Patient Safety Center. Along with that comes some funding from the state. And it's roughly every 5 years that the designation happens. And as the chairman said, the current designation ends at the end of 2025. I wanted to share with you, in case you haven't seen it recently, is what we're asked to do as the Maryland's designated Patient Safety Center by the commission. And that is work in hospitals, assure that hospitals actively participate in improvement projects, develop initiatives that align with Maryland's total cost of care model and now the AHEAD model as we're going forward, and the priorities of the Maryland Department of Health, and facilitate collaboration among a broad range, not just acute care. And I would suggest to you that I think these were written almost 5 years ago, 4 or 5 years ago. And I would honestly celebrate the commission for having a lot of forethought in taking a look at patient safety outside of acute care. I think you are, quite frankly, ahead of the nation in taking a look at patient safety outside of acute care. Patient safety has lived in the domain of acute care for decades. There's not as much science, there's not as much literature, there's not as much evidence, there's not as much information out there, there's not as much effort, but we're seeing this. We're starting to see it come through. But I think your work on this and having this in what you're asking the state's Patient Safety Center to do was incredibly wise and, quite frankly, ahead of its time. So I shared with you, next slide, please. I shared with you last time, and just as a very quick reminder, is that we're a very small nonprofit. We operate on a partially on a membership model. So most, but not all, Maryland hospitals are members of the Maryland Patient Safety Center. And we are also funded as the state's designated patient safety center. One of the things I also shared with you is that we are federally recognized as a patient safety organization, a PSO. That carries a legal protection for patient safety work product. It means we can share data and talk in a legally protected way so that we can work to avoid adverse events across the state and learn from each other. What it does not mean is that we have a whole bunch of data that's reported to us. The patient safety data that's reported is reported as level 1, which is the worst patient safety events to the Office of Healthcare Quality. And I wanted to share a quick anecdote with you about this. This time last year, roughly, the Office of Healthcare Quality put out its annual report on hospital patient safety. And what the annual report is reported level 1 adverse events. You might also recall that this was picked up by a reporter, and it had some interesting take on the increase in reported events in the state of Maryland. And it really sounded like Maryland hospitals, because it's a hospital report, Maryland hospitals were doing so much more poorly. That report is about to come out again, and we're expecting it in the next probably 2 or so weeks. And we've been working very significantly with the Department of Health and Nilesh Kalyanaraman about how we can be more proactive. So this report is more of a tool that we can learn from across the state. As we understand it, the Office of Healthcare Quality is incredibly proud of the fact that there have been more reports of adverse events. So the number of reported adverse events is going to go up. This is not an indication of how many bad things happen in hospitals. It is a measure of, do we have a culture of safety that encourages reporting? Do we have ways to learn from those? Do hospitals trust the Office of Healthcare Quality to report these level 1 adverse events? Because at the end of the day, there's a regulation, but they're self-reported. And so the number has gone up, and the Office of Healthcare Quality is indeed very happy about this. The reason I wanted to bring it up today is I wanted to share with you context, in that I believe later this afternoon, you will hear a report that shows directionally Maryland hospitals are going in the right direction as it relates to healthcare associated infections. Directionally, we have a ton of work to do. The American Hospital Association just put out a report that says healthcare associated infections and other healthcare acquired conditions are going down. We are going back to post-pandemic levels. It does not mean in any way, shape, or form we don't have work to do, but I wanted to give you context when you see the report from the Office of Healthcare Quality, because we have a ton of work to do. I think the other takeaway about that is that, with the aging population, and there's a whole bunch of statistics about the aging population in the state of Maryland, we've got patients with more complicated, multiple chronic conditions, and that puts them at risk, increased risk of adverse events. So this could be increased risk of a fall, and that could be in a long-term care facility, assisted living, a hospital, wherever. So our aging population makes it more likely that adverse events could occur in any of the settings that we're talking about. And we have more acute patients. So the acuity level of people coming into the hospital is higher. And so you would think we would see higher events. And this is in no way to absolve hospitals or healthcare organizations on doing the work of patient safety. Absolutely not. What it does mean is that we have to bring new and different solutions to the table to be able to continue to work on patient safety, because it gets harder every year for the reasons that I just described. And I do believe that we'll see hospitals and healthcare associations and us committed to help ensure that we keep that number going down, despite the environmental factors that might suggest otherwise. So next slide, please. I just wanted to quickly share with you, this is in the report, so I'm not going to go into detail unless you want to talk about anything in particular. I'm happy to talk with you. We look at part of our job as building capacity for the work of patient safety in the state of Maryland. We are not, at the end of the day, even as the Maryland Patient Safety Center, doing the actual work of patient safety. Patient safety has to reside by the people doing the work, the boards, and the administrators and the leaders that are doing patient safety. So we're working to build capacity through education and outreach, and we have a lot of different components of that. I'm happy to go into more detail. I'm cognizant that you want to be done by 3:30. Next slide, please. The other thing that we look at is strengthening the healthcare workforce. And so you might have heard that we received funding for a PR campaign around healthcare workplace violence. Healthcare workplace violence is a patient safety issue. Make no mistake about that. It is a patient safety issue because all of a sudden attention, resources are diverted to the workplace violence issue. It has long-term impacts on our staff. And so we really do need to address it. And we need to show our healthcare workforce, which you've all heard reports on, we need to show them that basically that we've got their back on this. And so the legislature funded $1 million for the PR campaign and then dropped it down to $750,000. That money flows through the Maryland Healthcare Commission, and we have just started working to develop that campaign. Teresa, who is amazing at threading through different programs, ensuring that things harmonize, has also identified that the Elder Abuse Task Force might possibly be considering a PR campaign as well, and there are absolutely linkages and lessons learned.
Just I think roughly related to this, there's some interest in some data out there suggesting that if people in healthcare settings had a little more training in recognizing people on the autism spectrum when they came in, some violence would be able to be prevented, because some folks who are tagged as being violent are actually autistic, and there are ways to deal with them that they're different. Is there any discussion or anything like that going on, or?
We are indeed across the state looking at the different sources, might not be the right word, but where and how and why is healthcare workplace violence happening? Because as we all know, and we'll get to your point, is this is a stressful situation. There is a lot of other behavioral health type of issues that are coming into play in different healthcare settings, but there are also unrecognized populations of patients. And I think you're absolutely right to point out we have a lot of work to do.
There's I know there's a program at MedStar that's being developed to identify and put in place procedures for dealing with autistic folks, and the idea of getting them better care and also preventing violence. Just a point of interest.
Thank you for sharing that. Part of the campaign will also be a toolkit for healthcare organizations, not just hospitals. And I think that would be wise for us to also ensure those linkages in the toolkit. Thank you for that. And you've heard us talk about the Caring for the Caregiver peer support program. Interestingly, this is like, the second victims that you've heard of when things happen. The number of calls for Caring for the Caregiver peer support, the percentage of those related to healthcare workplace violence has significantly increased. And so healthcare workplace violence is having a tremendous impact. Next slide, please. You've heard a lot about our how we support state health improvement goals for equity for mothers and babies. You've heard that severe maternal morbidity has increased and has significant health equity components. We're doing a lot of work, again, detailed in the report, but this is not just in hospitals. This is in primary care, community sites, pre-hospital care. We've done some training for MIMS, emergency medical services, on urgent maternal warning signs. We're working in EDs. Half of the deaths, pregnancy-related deaths, occur in the year postpartum. And so our EDs recognizing urgent maternal warning signs. If someone comes in with a headache, it turns out we don't always ask if someone is postpartum when they show up to the ED. So kind of embedding this in our systems so that it's not just, off the cuff in a stressful situation. To remember to ask is a lot of what we're doing. So we have a lot of work going on in this area. There are a lot of other work, the Department of Health, MD Mom, many other things, and we're working very hard to coordinate with them so that all ships can rise on this one. Next slide, please. Again, switching gears to patient safety in other areas that you are ahead of, and I think the Commission has delved into this with its January 2020 report on small assisted living. And I know that Teresa and Commissioner Boyle who is also on our board, feel very strongly about this, and I appreciate their pointing us in a direction. It's interesting, again, because of the lack of national focus in these areas, there's not a ton of data out there that says what's actually going on in these places. How do you get your hands on where the biggest levers for change are for improving patient safety in these settings? What we do know from national patient safety goals for these areas, things that you would guess are infections, patient falls, and pressure injuries, pressure ulcers, also called HAPIs, healthcare associated pressure injuries, bed sores. Again, this is actually similar to what you see in hospitals. It's a different environment with different challenges, but it is what you see. So we're getting directionally how we can adapt all the learnings from decades in the hospitals, but to make them unique to this setting. We actually took a look for assisted living, to the small assisted livings, kind of an informal assessment of why patients from assisted living were going to the ED, and it turns out falls. We actually tried to do a deeper dive, and we uncovered there's some depth to this. There's issues of resources, there's issues of workforce training, there's issues of accountability, all of which, you know, concurs with what was in the small assisted living report.
The data was pretty immense data.
We did use, again, because we're trying to find sources of data, and you'll hear that as a kind of a recurring theme, is that we worked with MIMS and identified the addresses of the small assisted living and identified then the 911 calls, where they went from the 911 calls. And then we were able to dig a little bit deeper into what those were. But again, the issue of data availability so that it's not quite so complex would be good. But there is a link also, Teresa's good at pointing out, if we can work on some of this, there's also a positive impact on ED visits. So there is some common threads.
And I would just suggest for context, falls, at least in the hospital setting, are a big issue as well, have been for a long time. It seems like really easy, low-hanging fruit, and a lot of it is, there's a lot that can be done, should be done, it's super important. But it's incredibly hard to, there's hard to drive them all the way down. And there's a part of it is just the human nature of patients as well. Right? I mean, if I'm in the hospital, I might not really want to ring the bell to get somebody to help me go to the bathroom. Right. And you can do all the things you want to do short of restraints, and you can't keep me from complying if I just say I don't want to do. And there's a fair amount of that. So just for people who haven't sort of had a deep dive in that, and I'm not suggesting you haven't.
No,
just for commissioners and people who are watching. Because the first time I heard that data, I thought, how can you not keep people from falling in a healthcare setting? It seems pretty easy, right? Really, really not.
I don't know, Mark, floors be slippery.
I mean, to that point, one of the, for our awards, we received submissions, and there's submissions last year on patient falls. And to a submission, there was a lot of talk about adding resources, meaning sitters. Is it realistic for someone to sit with every single patient? Again, we do risk assessments on patients and that kind of thing and identify the highest risk, but adding resources, and there's remote monitoring, there's all kinds of things, but there's no doubt also that there's got to be some additional technology. And I think there's some organizations that are bringing in innovative ways of using technology for falls, and taking a look at that and how we can spread that. But again, it is absolutely not easy. Pressure injuries, those are actually more common than falls, and some of them are associated with devices. There's got to be some good engineers who can help us figure out how to reduce that number. So I think it is complex. Adding resources probably not always the answer. So we would like to work in that space to help. Teresa also invited us to the Elder Abuse Task Force. CMS and others are actually starting to take a look at healthy aging and putting some measures in for hospitals to do a better job on discharge planning, social determinants of health, and that kind of thing. There are some direct linkages, and I think we can work very closely with them. We've done other work in nursing homes. We did a clean collaborative. There were a lot of patients, 60% of patients in early COVID were dying in nursing homes. We did a lot of work around cleaning and disinfection and infection prevention and that kind of thing. And those were successful. That was with some funding from the HSCRC. I think that could be duplicated going forward. So the same challenges exist in nursing homes and then some. There's certainly staffing issues in nursing homes, but culture of safety, which has been now extensively studied in hospitals, is certainly an issue in nursing homes and assisted living. And access to data, you know, what's reported, how do we know about it, how can we improve it is an issue. And then next slide. One of the other ways, you may have heard that the legislature passed a law this year. It's called Lauchlin's Law. And there was a young boy in Frederick County who presented to an urgent care center in Frederick County with symptoms of flu. He was told, he was given some, you know, ibuprofen and sent home, and he died within 24 hours, and he died of sepsis. And so Lauchlin's Law says that urgent care centers in the state of Maryland need to have protocols in place for recognizing and diagnosing sepsis and protocols for transferring patients to the appropriate level of care, plus training staff. And so we're working to spread this on urgent care centers. We have found that, you know, there's some big urgent care centers that know it and are doing it, but there's a lot of other urgent care centers. And so we are working to spread the word on this, increase sepsis awareness, tools for sepsis identification, prevention. But I'll tell you what, again, access to the organizations and getting out to all of them is certainly a challenge that we're working on. So last slide is what are we looking at for the upcoming year? And so we'll continue our building capacity. This slide looks busier in person. Sorry about that. You know, we are increasing our programming. I just was giving a webinar about patient safety in the emergency department while they're working on issues of throughput. We'll be supporting the implementation of Lauchlin's Law, increased focus on health equity, like I shared with you. We're encouraging all organizations to break down all of their measures by race, ethnicity, and some other demographics. We'll implement statewide collaboratives on patient falls, both in acute care and assisted living. Those are two different things, but related. And we'll work with Teresa and others to implement our healthcare workplace violence campaign. I have to end by saying I appreciate the collaboration with the Healthcare Commission and certainly Teresa for identifying ways that we can all work together, because I think with that collaboration, we make 2 + 2 = 5 across the state. So thank you. I look forward to coming back next time and sharing more of our strategic plan as we develop. So thank you very much
Thank
for
you
the
so much.
opportunity.
Yes. Other questions? All right, thank you very much.
Thank you.
You want to I'm sorry, go ahead.
And just, I wanted to note that Stephanie, you've submitted a report, this annual report to us too, correct?
Correct.
So if you commissioners want to take a look at that, feel free to and follow up with questions to Teresa. We can pass them on to Stephanie.
Absolutely. Happy to answer any questions. Thank you.
Thank you so much. On to agenda item number 7, a presentation on gender affirmation treatment in Maryland, 2022 to 2023, an APCD use case. On June 5th, 2023, Governor Westmore signed an executive order to safeguard gender affirming healthcare in Maryland. As a result, Maryland Medicaid began expanding gender affirming care on January 1st, 2024, in accordance with the Trans Health Equity Act, which was enacted following the passage of House Bill 283. This report explores gender affirmation treatment services for members with commercial Medicaid insurance, offering useful data on enrollment types of services and costs. It provides details on the number of providers across counties offering these treatments, the nature and cost of the services. This baseline information is aimed at guiding policy decisions and enhancing gender affirmation healthcare in Maryland. Shankar Mehta, Chief of Cost and Analysis at the Center of Analysis and Information Systems, will update us on this report. Sir, please proceed.
Thank you, Mr. Chairman and Commissioner. Good afternoon, everyone. I'm pleased to present the key highlights of this report on behalf of my division today. This report aims to describe, as Mr. Chairman described, the distribution of gender affirmation treatment services using the APCD and shows the utilization during 2021 to 2022 period. Next slide, please. Gender affirmation treatment service is very important to transgender and gender non-conforming people. It helps them look and feel the way they identify, reduces their discomfort with their gender, and improves their mental health. Transgender people have a hard time getting the medical care they need. They often face discrimination, struggle to find experienced providers, and have trouble paying for treatment because it's expensive and not always covered by insurance. Governor Westmore took action and signed an executive order on June 5th of 2023 to protect the gender affirmation healthcare in Maryland. As a result, Maryland Medicaid began expanding the gender affirmation care beginning Jan 1st of 2024 in accordance with Trans Health Equity Act. Considering the increase in the demand for gender affirmation treatment services, this study's purpose is to describe the distribution of gender affirmation treatment services in Maryland using the APCD and show the utilization during 2021 to 2022 period. Next slide, please. The Maryland All Payers database contains information from the commercial payers, Medicaid, and Medicare, consisting of the medical, pharmacy, and dental claims. The data gives details about the services provided, where the services were provided, the diagnosis, the procedure codes, the allowed amounts, and the reimbursement amounts. For this analysis, we examined the claims from the commercial and the Medicaid population for the years 2021 to 2022 period. We did not include the Medicare and uninsured population in the study. Next slide, please. So in this analysis, the study population was identified based on the diagnosis codes provided in the Washington State Office of the Insurance Commissioner report. We identified transgender members in claims as those with a minimum of 2 or more claims containing the transgender diagnosis code in any position. We categorized the procedure codes in the claims into behavioral health, office visits, surgical procedures, and medical treatments in the pharmacy claims. Additionally, we used the pharmacy claims to identify prescriptions for androgens, estrogens, and pituitary suppressants. To calculate a service, we required that the office and the behavioral visits include a gender dysphoria treatment diagnosis, and the surgical and the pharmacy services were assumed to be more specific and did not require a diagnosis code in the claims. Next slide, please. Next slide.
Sometimes it's lag.
Can we move to the next slide, please? Yeah. You're on. Okay, thank you. So during the study period, 8,858 patients, which is about 0.2% of all patients covered by commercial and Medicaid plans, were identified as transgender, using the diagnosis code in their medical claims. The percentage of transgender patients was slightly higher in the commercial plans compared to the Medicaid managed care. This is in contrast to the study finding that in the Washington report, which reported that the Medicaid managed care had a slightly higher percentage of transgender patients compared to the commercial population. Next slide, please. The transgender patients with commercial and Medicaid coverage tend to be younger, with nearly 39% of them falling into 20 to 29 age groups. Older age group have a lower percentage of patients diagnosed with gender dysphoria compared to the overall distribution of members in those age groups. This data doesn't include the Medicare population, so it doesn't represent the adults who are over 65 years of age. Next slide, please. The Baltimore metro area has the highest number of transgender patients with 4,023 individuals, making up to 45% of the total study population. The DC metro area follows with 2,054 transgender patients, accounting to 23%. It's interesting to note that 990 transgender patients which is about 11% of the study population, were living out of state. Next slide, please. Based on the study criteria, we identified 69,222 claims with gender affirmation treatment diagnosis in any position. Overall, 7,880 patients received the gender affirmation treatment services during the reporting period. These patients received care from 5,069 providers and retail pharmacies. 90% of the transgender patients with the diagnosis of gender dysphoria had an office visit. 36% of the patients received mental health services, while only 9% had medical procedures. Over 93% of all services were provided by in-network healthcare providers, except for retail pharmacy services, where this status was not available. I think we already have skipped to the next slide. So if we can stay on this slide, please. So this slide tells us about who paid for the gender affirmation treatment during the study period. The biggest payers on the commercial side were CareFirst and United Healthcare, with 27,013 claims from CareFirst and 6,685 claims from United Healthcare. In Maryland, about 93% of the healthcare was provided by in-network providers. This means that most people in our study population received care from the providers and or hospitals or facilities that were part of their insurance plan network. For commercial plan, it was 90% of the claims were from in-network providers. And in Maryland, we don't have out-of-network benefits for the Medicaid population. Next slide, please.
You go back to slide number 8, where you break out the treatment by service type. So maybe I missed it, but the second largest group there is office visits. Are those office visits specific to gender affirming treatment or office visits in general?
Good question. So when we try to break down the procedure codes into different service type for the office visits and for the behavioral health, we had an additional criteria that those claim lines should also have a diagnosis code for gender dysphoria, so that it's more specific, because as with office visits can be very non-specific.
If you go in for flu, it's not in this number.
It will not be included because.
Yeah, that's a a good screening measure, but practices vary in terms of whether they code multiple diagnoses, historical diagnoses. You come in with flu, you might come back later for some other checkup. That flu diagnosis could conceivably still be on claim form. Shouldn't be, but so it's the best we could do based on.
It's not perfect, but we're trying.
Yeah.
Got it.
We're trying to be more specific, but there can be claims where it might be not absolutely the main reason was that for the gender dysphoria.
I have a question. While we're on this slide, what's the definition of procedures? Like, what type of procedures are these patients getting?
Sure. For the procedures, when we looked and all the details we have provided in the appendix of the report, and it contains the procedures that the patient might have gone for. If I want to give it a high level, it can be the surgical procedures, like the top surgeries, the bottom surgeries. Those are the two main classifications of the procedures, and there are also like other procedures they might have gone for the facial or the hair transplantation. So we try to capture all the different CPT codes that can possibly map to those procedures. Okay, to move on. In this slide, we see that the Baltimore metro area has the most gender affirmation services with the highest number of patients and providers offering those services. Almost half of the 7,880 patients who received these services were from Baltimore metro area, which is about 3,660 patients. Out of 7,880 patients who received gender affirmation services, 1,452 patients lived in Baltimore City alone. Next slide, please. So 5,069 different healthcare providers offered gender affirmation treatment services in the study population. Out of those, 355, which is about 27% served people who lived outside of the state. The number of providers differed by location, with a maximum of 1,159 providers in the Montgomery County and only 16 providers for Somerset County residents. Next slide, please. So on average, the cost per patient for all services included was $1,699. The procedures and pharmacies in medical claims stand out for their higher cost per patient, which is about $6,614 and $6,662 respectively. This suggests that these services involve either specialized treatment or very expensive medications. On the other hand, office visits and retail pharmacies services were much lower cost per patient. Next slide, please.
Excuse me 1 second. On that slide, the per capita medical cost, is that per Maryland resident? Or is that per patient who received gender affirming treatment?
This is per patient who received their treatment in the study population.
That's the $3.59.
That's
All right.
$1,699. Am I looking at the right now?
The per
Per capita medical, yeah. Oh, sorry, I was looking at a different number. I take back my answer, sorry.
It would seem to me that the per capita medical is for the entire Maryland.
For the entire population, which was part of the total enrollees. Right, just confused with the question over the.
Gotcha.
Yes, sorry.
Is that annual or monthly?
That's an annual cost.
Okay. Thank you.
Yeah, we can move to the next slide, please. The social workers, can we go back to one slide? Yeah, thank you. The social workers made up the largest percentage, accounting for 23% of the total 46,633 commercial claims. They were followed by nurse practitioners and psychologists. Among physician specialties, internal medicine, family medicine, and pediatrics also made significant contributions. And the other provider category included services that were provided by non-physician specialties, which is not listed in this, but we tried to provide all the list of taxonomy codes that we included as part of that in the report appendix section. Next slide, please.
One more question. The social workers, what were they billing? What services were they providing?
Yeah, for this distribution analysis, we did not go into the type of services billed by each provider. We looked into all the services and then we tried to identify what were the taxonomy codes as part of those claims. So we did not go into that next step of granularity of finding out for each provider specialty what type of services were billed. But that might be a good question for the future study. All right, so the final slide. So during the study period, 7,880 patients enrolled in commercial and Medicaid programs from Maryland or other states received gender affirmation treatment services. They were attended by 5,069 providers and retail pharmacies. The transgender population was concentrated in those younger than 40 years of age. The Baltimore metro area, being the most populous Maryland Insurance Administration rating area, had the highest number of transgender patients, followed by the DC metro area. The number of providers at the county level varied, with Montgomery County having the highest number and Somerset County with the lowest. The Baltimore metro rating area had the highest number of providers offering gender affirmation treatment in each service category, totaling about 2,125 providers across all categories. Among the 5 large commercial plans, CareFirst and United Healthcare paid the majority of claims. And in terms of services, office visits had the highest number of providers, followed by the behavioral health visits and retail pharmacies. Around 93% of the healthcare in the state was provided by in-network providers, with commercial plan showing 90% of claims as in-network. And overall, the average cost per patient for all services was $1,699. And social workers accounted for 23% of the total 46,633 claims. This concludes my presentation. Thank you.
Thank you very much, Shankar. Further questions for anybody?
I just wanted to, put this in context of, Shankar mentioned that this is a study that was done in state of Washington. We had some initial meetings with them, and given the governor's executive order, we thought it would be a good idea to get this is data before the executive order, so we can kind of, as we're moving forward, see if what the impact was of the executive order. Of course, the assumption is that greater awareness, greater visibility would improve access, but we thought it important to get a baseline on this. Keep in mind that we are dealing with 100% of the Medicaid population and about 60% of the commercially insured. Under federal Supreme Court decisions, we can't get insurance claims from what are called ERISA exempt private employers, which in Maryland maybe represents about 30% of the market. The federal government employees, which represent about 10% of the employment base, so perhaps 10% of the insured population, beginning several years ago, stopped allowing that data to be submitted to states, not just Maryland. So its commercial population represents probably about 60% of what it is. I don't want to say multiply it by 0.14, but the number for the commercial population is probably larger than it appears in this study.
And again, the claims are just claims where one of those select diagnoses was present on the claim, with regardless of whether it was the primary reason for the visit or, as we're taught in documenting, document thoroughly every diagnosis you can that's appropriate. So it could be someone seeing for hypertension, but also has gender dysphoria disorder, and incidentally, that's billed out. It's hard to know which was the primary cause for that or primary reason for that visit then.
Absolutely, yeah. Because when we approached this analysis, we were expecting a very slow number compared to the entire population. So we had to kind of come to an agreement of how specific or how sensitive we are going to be to identify these members. So if we had narrowed only on the primary diagnosis, then our population would have been much smaller, in my opinion. So we had to expand it and consider the diagnosis code in all the different positions. And you're absolutely right that this might be attributed to that particular diagnosis code, or it might be one of the diagnosis code that was captured, but the primary reason might be different one. Yeah.
Thank you. So I understand this is a baseline to get us started. So I assume our next steps, if one of the challenges that were listed had to do with awareness of providers, I think it would be a good idea going back to the talk about the difference in the claims over between social workers having 23%, then followed by psychologists and nurse practitioners, that we look into that. I understand for a broad view, it was just a part of the claim, may not be primary. But as we go further, I think that would be a good area to dive in and get more information.
Absolutely, and I think your comment and feedback, I think it touched upon the most critical thing of this distribution study, which is, we talk about all the expensive medications and the surgeries required to help this population, but the data is showing that the majority of the care is provided by the mental health providers like social workers and the counselors. So one of the takeaway from the study would be to focus on how we can create more awareness among this particular provider specialties to become more sensitive about the care and needs of this population as the demand increases.
Great.
Good report.
Yeah.
Thank you so much.
Thank you.
On to agenda item number 8. Presentation, update on healthcare associated infections in Maryland hospitals. Since fiscal year 2009, the Commission has monitored the performance of hospitals and other healthcare providers in preventing certain healthcare associated infections. HAI and HAI information is collected to facilitate quality improvement as well as to inform consumers as they make important decisions about their healthcare. Courtney Carta, Chief of Hospital Quality Initiatives, will provide an overview of our HAI public reporting initiative and summarize how hospitals have been performing on key evidence-based infection measures. Courtney.
Thank you for the introduction. Good afternoon, commissioners. So Stephanie set me up perfectly a little earlier talking about HAIs. So we can go to the next slide. So just a little bit of background before I get into the results. So healthcare-associated infections are infections that patients get soon after receiving healthcare. So you don't want to go to the hospital and end up sicker than when you came in. So it's an important indicator of patient safety. And HAIs are considered to be largely preventable. So MHCC has been publicly reporting on this data since at least 2010. And we pull this data directly from CDC's National Healthcare Safety Network, NHSN for short. This is the gold standard for infection surveillance. Almost every hospital in the country uses this program. And so hospitals are required to enter this data into the system regularly. And the results are used for a number of different things, including public reporting, payment programs, quality improvement initiatives. If you're familiar with Leapfrog hospital safety grades and various CMS star ratings of different hospital ranking systems, all of those use infection measures. So they're a really important quality metric. Next slide. So our reporting requirements generally align with CMS requirements. There's 3 different types of infections that we look at, and the first is device-associated infections. So it's catheter-associated urinary tract infections, or CAUTI for short, and central line-associated bloodstream infections, or CLABSI for short. I've got a lot of acronyms today, so if I confuse anyone, just let me know. And so these types of infections are location-based. So reporting is only required for certain units within the hospitals. So we look at ICUs and then certain non-ICU wards, like medical and surgical wards. And then for CLABSI, we also look at NICUs. The next category is multi-drug resistant organisms. And this is measured facility-wide. And we look at Clostridioides difficile, which is C. diff or CDI for short, and methicillin-resistant Staphylococcus aureus, MRSA or MRSA for short. And these are some of those nasty superbugs you kind of hear on the news. They're really hard to treat. They take a lot of strong antibiotics to get rid of. And then the last type is surgical site infections. So these are procedure-based. We look at a number of different surgery types, and this includes colon surgery, abdominal hysterectomy, coronary artery bypass graft or CABG, hip prosthesis, and knee prosthesis. And so the last 3 procedure types, CABG, hip, and knee, those are Maryland requirements. Those are not CMS requirements, but as a state, we do require hospitals to report those infections. And this last bullet point here maybe looks a little bit out of place, but this is healthcare personnel influenza vaccination rates. So how many staff are getting vaccinated against the flu? And so this is not an infection per se, but it is a preventive measure. And so this data is entered into NHSM. So this information is often grouped with HAI information. Next slide.
Are there any COVID vaccination rates included in the report?
COVID is included as well. We actually download that data from CMS. It's kind of a tricky measure of the way it's entered into the system. So we don't pull that one specifically, but there is COVID data. Good question. Okay, so just a couple of notes before we get into the results. So infections are not measured in the standard rate. They're measured in what's called a standardized infection ratio. And so just it's theoretically a simple calculation. There's a little equation down in the bottom. It's the number of observed infections over the number of predicted infections. And so that denominator is calculated in the NHSN system. And it uses different variables that are associated with incidence of infection. And so for today, just to kind of keep it high level, the most important thing to remember is lower is better, and you want the SIR to be below 1. If it's lower than 1, it means there are fewer infections than predicted. If it's right around 1, it means kind of average, that's what we would expect. And if it's higher, it means there are more infections than you want to see. So.
It seems like if we have success, the SEER will never improve. Because if we have success, we'll have lower infections, lower predicted infections. And so it seems like there's a
So.
limit to how good we can get that.
Until you get to
indicator.
zero.
So 0 is
Well, then you
ideal.
predict zero, so it's infinite.
Right.
But
Zero over zero would look pretty good.
Y'all going to math now?
Yeah, we're throwing out math, yo. Anyway, sorry, just
No,
trying to look at that as, you know, it's
So
not an
the-
absolute, so, yeah,
So the baseline is, so it takes all of the collected data from 2015 from the nation in NHSN. So that is.
stay with that same baseline. for predicted.
So you're getting to my very last slide. And so every few years, CDC does re-baseline. So you're essentially, everyone's making progress as a country. And so now we're saying, okay, your baseline is here. Now we're moving it up here. So that's the re-baseline. So we are due for one. So I don't know what the data will look like next year.
So when a
It won't-
reporter sees that and shows that the SEER is worse this year, he'll think we're failing, or she will think we're failing, when in fact they recalibrated our baseline.
It would come with an asterisk. You'd have to explain that, a footnote.
So in some healthcare systems that I'm familiar with, these numbers are presented as this ratio, but then you just get the raw number as well. So for CLABSI, you know how many, so you can track it internally just that way. And then sometimes it's presented in a ratio related to patients. Like not a predicted infection, but we did this many, we put this many catheters in and this many people got an infection. So it's presented perhaps
So-
3 ways.
So NHSN does have
You
utilization.
probably can't do that. I'm just
You can do a little
talking
bit.
to my fellow.
You guys are getting ahead of me.
Oh,
Some of it's over patient days too, to be fair.
So there's patient days, there's utilization, there's, so
Gonna make you.
Yeah.
the system is really robust. I was trying to keep it simple today, but maybe I should have gone a little more technical. So the data I excluded 2020 just because we didn't have a complete set of the full year of data for obvious reasons. And then we don't have 2023 national data to compare yet. So it might look like there's a bar missing. It's not missing. We just don't have it. So we can go to the next slide. Next slide.
The slide answer from the copyright. Mark and I start talking.
Yeah. It's like the guys and gals in the tower watching fires out west, right?
Oh, yeah,
It's
right.
pretty boring, but as a fire, you need it.
There we go. Okay. So let's get into the results. So I'll start with the device-associated infections. So I want to go through one of these charts because the next few charts look pretty similar. So the bars that you see represent the SIR. So again, lower is better, less than 1 is what we want. And so the yellow is the state of Maryland, and then the red is the nation. So that's the SIR, and then the blue line is just your raw number of infections. And so if you're confused about the SIR, it's a little conceptual. The blue line is kind of a nice, easy line to look at to kind of understand what was going on.
That infection count, is that across all hospitals in
Yes.
Maryland?
It is.
So just curious, thoughts on why both Cardi and CLABSI went up in 21?
There was still some hangover from COVID 2020 data.
Okay, so some of the early COVID data is coming into 21. Got it.
And so you see the results are a little bit more drastic with CLABSI. The SIRs are a little bit higher and on the right there. And we haven't quite gotten down to pre-pandemic levels yet. We're still pretty high or higher than we've been in the past. And so just some historical background. I think back in 2008, there was an article, Maryland had the worst CLABSI rates in the country, super, super high. And then, but have as a state worked really hard, and now we have had pretty good CLABSI rates.
It's something else that I've seen on some internal reporting that just talks is also including for each category, the mortality rate. Sort of, in other words, kind of know which ones are going up and down and which ones kill the most people.
Yeah. And so when we look at CLABSI and CAUTI, I mentioned a little earlier, they're location based. So we can tease this out a little bit more. We can look at the ICUs versus the non-ICUs. And really what we find is that the ICUs were hit hardest during COVID. And so it makes sense, right? Because there's a higher acuity of patients, there's a longer length of stay, device utilization is longer, prevention practices maybe kind of went by the wayside, dealing with staffing issues and such. So MDH and some other partners have worked.
Sorry, one more thing, on the CLABSI, if there was just more, you know, during COVID, we had more ICU patients, more patients receiving intensive care, more patients receiving central lines. With the fact that there's so many more central lines per hospitalized patient, that would probably, and you know, there'd be more opportunities for infection. Would that help drive these numbers up if we were
That's
just doing
definitely-
more of that risky behavior?
Yeah, so a common practice to reduce infections for these types of devices is to move them as soon as you can clinically. And so the longer you keep them in, either because you don't have staff who can get to the patient quickly, or for whatever reason, maybe they're sicker and they need these devices in longer, definitely increases the risk. So
can I just add a point to that? I think your point's well taken. And though those patients would have a higher predictability of infection. So theoretically, that's why the SIR helps you. You would have more infections, but you have more people with a higher predictability to get infected. And so I think that's supposed to be the reason for
Normalize it,
SIR.
yeah.
Yeah, but to your point, when you had to leave these things in forever because you didn't have sterile equipment, you didn't have people, and we weren't
We
following.
had people in intensive care settings far longer than
Right.
we've had in any recent history, yeah.
Right, and they may not have even had sterile equipment to change the line. So I think like both, it's sort of outweighed the SIR a little bit.
Yeah.
And so this, the state data is also similar to what the nation saw as well. We're not an outlier. But MDH and some other partners have, they hosted a learning collaborative. A lot of different people have presented and really tried to get back to best practices, back to basics. And we're starting to see these numbers directionally go in the right way. Okay, next slide. Okay, so the multi-drug resistant organisms. So C. diff here on the left is a beautiful slide or a beautiful chart. The bars are really low, well below 1, and you'll notice that there was really no difference during the COVID years in Maryland or in the state. The numbers keep going down. And so some of the literature pointing to that is some increased focus on hand hygiene, environmental cleaning, patient isolation, more PPE, antibiotic stewardship. So C. diff has looked really good for a long time. So that's one kind of bright spot among all these. And on the right is MRSA. Can't say quite the same. And so our performance for MRSA has been okay as a state. And then same with national, we see a bit of an increase in 2021. Our performance is a little bit better than the nation, but we are actually going down quite a bit. 0.57 as the SIR is actually the lowest it's ever been. That is not statistically significant. It's still considered average, but it's good. I'm really happy with the results compared to what we've seen in the past.
So just these absolute numbers seem very, very low to me. Of all the hospitals in Maryland, only 110 MRSA infections that occurred in a hospital.
That meet the NHS-NAMS definition, surveillance definition. Yeah.
Interesting.
Okay, next slide. All right, so the last group of infections are again those cervical site infections. And so we didn't see a lot of impact from COVID, mostly because, well, number one, there was a moratorium on elective surgeries in 2020. But also the ORs are more of a controlled environment, sterile, organized. The process didn't really change. So if we look at colon surgery, We haven't seen too much of a change in Maryland or the nation. There was a dip in that number of infections in 2021. I'm not really sure why, because the procedure count is pretty similar to years past and after that as well. So not really a lot of change there to report. And then if we look at hysterectomy on the right, this has sort of been, I guess, a thorn in the side in Maryland for a long time. So you'll see the yellow bars, which is Maryland, much higher than 1, much higher than the nation. We have been consistently performing worse than the nation for years. And so essentially, when we look at the infections, we can attribute it to usually 1 or 2 hospitals each year. Not the same hospitals. And so it's a little bit like whack-a-mole. It's hard to predict. And so when we see numbers that look off or just really wrong, we do a couple of things. First, we reach out, we make sure that what they entered is accurate. And then we ask, what's happening? What's the issue? Why do you have so many infections? And then we want to know what they're doing about it. And so we've had several hospitals in the past who have really improved. They had really high infection numbers and they implemented all of these different interventions and have had 0 infections for like the past 3 years. So we can facilitate, we can get these facilities in contact with each other. We can say, hey, why don't you talk to these people? They know what they're doing. They've got good success. So we try to do that when we can. And we also follow up. We do regular check-ins, make sure things are going okay. We can pull the data anytime we want. So we can look in and we can say, hey, it's been 6 months and your numbers look good. Whatever you're doing is working, or maybe let's redirect or try something else. So we do continue to monitor this infection type closely. Next slide. Okay, so hip and knee. Hip is on the left. Our performance has been kind of consistently similar the past few years, a little bit better than the nation. We're below 1. Our infections have increased a little bit since 2021, but it's not significant. Performance is still about average. And then on the right with knee, similar, our performance hasn't changed too much, doing a little bit better than the nation. And the infection count has varied a little bit.
Is this just hospitals?
Yes.
What year did Medicare say you could do it in an outpatient, in ambulatory surgery?
Sorry?
I'm wondering what year Medicare started paying for it in ambulatory surgery, because that would change the predictability of the hospital patients.
That was prior to 2020.
Before that. Okay, thank you.
We're probably picking up some evolution of it moving into the outpatient setting, but CMS issued, I want to say 2015, a while back.
So, okay.
And then next slide. Okay, so this is our last infection type. This is CABG. Prior to 2019, including 2019, our performance was pretty good as a state, statistically better than that 1.0 baseline. It's starting to creep up a little bit, but we're still well below 1, kind of considered average at this point. And the number of infections has also kind of crept up. So we'll continue to monitor this one as well. Next slide.
C-section, do you track C-section infection rates?
No, it's not a requirement. It is in NHSN, so hospitals can track it on their own if they want. There's a huge list, probably at least 50 procedure types that can be tracked. Okay, so the next couple slides should go quickly. This is just staff vaccination rates in hospitals. Every hospital in Maryland does have a mandatory flu vaccination policy. And we are typically, as a state, among the top in the country, usually in the top 3. We've been 97% for a really long time. The past couple of years, it's gone down just a little bit, about 94, 95%.
Can we go back to just CABG for a second? If you look at, Commissioner Brzezinski brought this up, and I'm looking at this now, and I'm thinking about numbers that I've seen internally for a healthcare system. And those infection count numbers just look really, really low. And I understand you said it's because of definitions, perhaps.
the
Right.
definitions, but there's also only 11 hospitals in the state that do CABG procedures.
But that means you had one infection per hospital for a year. That seems,
I don't believe that either.
that seems super low. I'd kind of be interested in a deeper dive on those raw numbers. It just doesn't make sense to me in that context.
And it's just two flat, like when we're reading it, 4 flat.
But when you go back through the other, have sort of the same reaction to the raw number of infections in most of the categories that we've seen, that the numbers just look too low based on what I've seen internally for a
Sure.
system.
And so I'll also add to.
Can I,
that,
can I interject? Commissioner Jensen, this is cabbage. 15 infection in cabbage is high number. This is a serious surgery.
15 is high for 11 hospitals?
Cabbage, see the type of surgery.
Yeah.
I'm not sure I understand.
It's a cabbage, it's a heart surgery. It's
I
cardiac.
understand that.
Yeah, that's a high number. You don't want to
So,
have this kind of, in this kind of procedure.
But you divide that by 11 hospitals and I think it's a low number.
No, if this was a knee surgery or something, I will say it's not cabbage.
So just, I mean, I think there would be about 2,000 to 2,500 cabbages per year. So, I think we should we recognizing the time of the day and.
Yeah.
We should follow up on this. We'll work with
Yeah.
Eileen's team to look at, I think we have.
And I have procedure counts and everything, so that we can easily get that. And so,
And I don't want to blunt, but it'd like to be interesting to me to hear back on how you calculate it internally, but also if there's any possibility to reach out to healthcare systems and see, does it measure up with what they're reporting internally?
and so we do work with the hospitals before we report anything. We send numbers back to them and say, please review this. We also have the ability to audit data. We haven't done it in a couple of years. We are talking about doing that pretty soon in the near future. So that's something too that'll be.
To that point, is there any, so I've been out of this for about 2 years, right? And from my recollection, it was sometimes hard to get realistic data related to infections. Like if somebody didn't come back to your ER or a physician practice self-reported that, it was always a struggle to get more. Is it easier now?
No. Okay, so I know we're kind of low on time. Do we?
No,
Okay.
move on.
Okay.
Mark and I'll be quiet.
So vaccine rates for hospitals, pretty good, pretty high. We can go to the next slide. So we also collect flu for ASCs in our annual ASC survey. About 50% of ASCs have a mandatory flu policy. Their performance is pretty good, between 80 and 90%. We actually just got the most recent data this morning, so they're sitting at about 81% in the most recent flu survey. So we don't have national data to compare. That was taken out of CMS payment policy back in 2017. That was the last data point we had, but when we did compare, our data was a little bit better in Maryland compared to the nation. Next slide. All right, and so we also collect flu data for a number of different long-term care settings or facilities. It really varies by facility type. And so you'll see nursing home in yellow, and then in the dark blue is hospice. They tend to have some of the highest flu vaccination rates, followed by home health and then assisted living. And so we didn't start collecting home health and hospice until 2021. So that's why there's ours there. And then the mandatory vaccination policies definitely vary by facility type. Nursing homes and assisted livings, under 50%. Home health, only about a third of them require the flu vaccine, and then hospice, actually 2/3 require the flu vaccine. Okay, next.
I'm sorry, I can't help it. So here's your question, sort of to you. We know that nursing homes with COVID, for example, it was a real tragedy, you know, at least in the beginning and lasted too long. And so if we know that in hospitals, the mandatory requirements for vaccination, isn't that enough coupled with the data and the outcomes in nursing homes for there to be some opportunity to make it mandatory?
Yeah, I mean, I think there are opportunities to do that. I think that, you know, obviously the industry is going to resist that even as they support the fact that they want workers vaccinated. But, you know, that is a possibility. Certainly, when Dr. Pollack was here, you know, he outlined the iron rule of vaccinations, I think at UMS, which was, you know, you either get vaccinated or you don't work here. I don't think there are many nursing homes that are going that far, partly because of significant workforce challenges they face. But it's something we can pursue, I think, as a way to reinforce this. I mean, you know, what's not hidden is COVID vaccination rates, which even in nursing homes, probably the last couple of years have hovered around 50%, if that. I think flu is important, but, you know, trying to combat, you know, vaccination weariness as well as vaccination hostility is a big challenge. And I think we've seen a dip in flu vaccinations just because of greater hostility towards vaccinations in general, slight dips. But we'll follow up. Thank you.
And just to wrap up, I know I threw a lot of charts at you. So we saw some infection types increase kind of dramatically during the pandemic, but results are improving in Maryland and nationally, particularly for those device-associated infections, CLABSI. And then MDROs, C. diff continues to perform and go in the right direction. MRSA is also, performance is pretty good. And for surgical site infections, performance is kind of consistently average, with the exception of abdominal hysterectomy. So we'll continue with that follow-up work. We'll continue working with our partners, MDH, HSCRC, et cetera. And then we talked about this a little bit earlier, but CDC does plan to re-baseline that denominator data. So our results for 2024 probably look a little bit different, but that's good because you want to drive improvement. You want to give people something to work towards and achieve in terms of low infections. So any questions?
Oh, thank you so much, Corey. That's a fantastic presentation.
Thank you.
Thanks for putting up their interruptions, but it's a very interesting topic, and thank you for it. Moving on, agenda item number 9, overview of upcoming activities. Sir, would you like to share your?
Sure. First off, I want to thank Commissioner Wang for chairing this meeting today. I'll report back to the permanent chair on the stellar performance. Commissioner Wang will go back to his usual role of Sergeant at Arms for future meetings, but greatly appreciated today. The behavior of some will also be reported as necessary. But for bring your sleeping bags in October. Right now we have 11 agenda items. A couple of the highlights are we do have a CON application. We'll be hearing more from Eileen's team on certificates of ongoing performance for hospitals that deliver pre-CI services. Tracy and a consultant have been working on the behavioral health workforce assessment study that's due at the end of October. Maybe it's first, but this will be the first opportunity. I think you've seen some preliminary data. Preliminarily, it has been presented at various other state meetings and has gotten good responses, and I think it's well done. We'll have a report on hospice utilization. And finally, David will get a chance to deliver his reports on telehealth and on the primary care investment goals. That report on the primary care investment work group, those recommendations are due to the legislature this fall. So pretty significant. And last but not least, Dr. Mesta is going to make a return performance, hopefully, and present on weight loss drugs. Certainly something I've heard something about press, but I think there's a surge in utilization. That's what rumor has it, and we'll report to you what we see. 23 will be the tilt point, I think, for the data. We decided we had done this earlier, but on 22, and public attention and awareness of these drugs was not as great as it was in 23, and of course that enthusiasm is only continuing. So thank you all. Thank you again, Dr. Wang, and I look forward to seeing everyone next month. I will send out, try to keep it to 2 pages on the various reports that are going to be due over the next couple months as we move forward.
Can I ask a quick question? Sorry, I know everybody wants to leave and you can report me to whatever police that is. I'm having trouble with my conscience. Is there a procedure to change one's vote on something that we voted on today? Or are we stuck with our vote?
I'll have to deal with the council on that one. I mean, I think that there would have to be a motion to reconsider, and then the vote would have to be done. But I don't know.
We'll take it under advisement. We'll come back to you, I think.
Good. Thank you.
So before I move to adjourn, I just want to make one quick comment. At the end of our last meeting, of course, Ben announced his impending retirement. I just want to take this opportunity while I have this chair to thank Director Seven for his many, many years of dedicated hard work. It's been my great fortune to work with Ben ever since I joined this commission and to witness not only the depth of his knowledge of the healthcare system, but also the depth of his compassion and care for all the people of Maryland who rely on the functioning of that system. And Ben, I know you'll be getting many, many plaudits in the months to come, but please allow me to add my thanks and appreciation for everything you do for Maryland.
Thank you very much.
Thank you. Do you have a motion to adjourn the public commission meeting?
So moved.
All right, Commissioner Jensen's been, yes.
Want to make a motion to reconsider if you should do it now during this session.
All right, which one do you want to do?
The one where we talked about the quality if you're not at 3 stars for nursing homes.
Yes.
That was agenda.
That was a regulation adoption as proposed.
Or
Yes.
2.
Yeah, I think there's actually one slight clarification in the presentation. The regulations are correct. That there was a slide that said if you have 3 stars or below, you have to report on all these things. That's not exactly correct. The only kind of standard that applies to 3 and below is that you have to provide an additional analysis. But the rest of the list that's reporting on lawsuits, that's reporting on whether or not you're a special focus facility, that applies to all of the nursing homes that they own, either in state or in the state. That was the issue. I wanted to make sure that.
She was the additional criteria tweaked.
Oh, 2 weeks. Okay.
Is that 10.2401 or is that
10.20?
20? Okay,
The motion on the second.
we'll go back to that. Then do we have a motion
To reconsider.
to reconsider? I guess to reconsider approval.
Why don't we just open it back up and everybody can just be cast through.
Okay.
We have to have a motion to reconsider, right? So I move we reconsider.
Okay, and is a second? Okay, we got a second, Commissioner, so Commissioner Jensen, Commissioner Duncan. Okay, all in favor of approving motion 10.24.20, State Health Plan for Facilities and Services, Comprehensive Care Facility Services. All in favor?
Aye.
Any opposed? Opposed, Commissioner Gelred. Opposed, the State Healthcare Plan is hereby approved. Thank you very much.
All right.
Good.
We move to adjourn. Commissioner Jensen made a motion.
Second.
Second.
How are you?
Krasinski? All in favor?
Aye.
Commissioner Gelred, you sure? Okay.
My God.
Thank you very much.
Don't give her that chance. We could stay.